very much to the course directors for the invitation to be here today and to be a part of this amazing course. It is such an honor. I will be speaking today on endoscopic gastroplasty outcomes. This is very much a changing landscape, and so it is an exciting time to think about all of this. These are my disclosures. Before I jump in, I wanted to quickly start by framing the obesity epidemic within the United States. Here you can see recently published graphics from both the New England Journal and the CDC showing that the prevalence of obesity and severe obesity has been steadily increasing in the United States. And of course, the impact of obesity on morbidity, mortality, and healthcare costs is profound. And it is important to note that all states and territories have more than 20% of adults with obesity, and most have more than 30% of adults with obesity, with the Midwest having the highest prevalence. However, fewer than 1 to 2% of patients eligible to undergo bariatric surgery are actually undergoing these procedures. There are many reasons why bariatric surgery is being performed at such low percentages, including lack of access, strict eligibility criteria, substantial cost, and non-negligible morbidity and mortality. Given this high risk profile, it is important to balance risk and efficacy when we think about the spectrum of obesity management. Here you can see that standard lifestyle interventions, which are very low risk, also only result in about 3 to 5% total body weight loss. Medications have historically had lower efficacy, and while the newer medications are becoming much more effective, they have side effects, are costly, and oftentimes difficult to access. Surgical procedures are very effective, but as we discussed, they're also much higher risk. And so we think that endoscopic, bariatric, and metabolic therapy really fills the void between these two extremes, offering alternative treatment strategies for patients. And while we will review some of these in more detail, you can see that endoscopic interventions generally lead to 15 to 20% total body weight loss, whereas surgical interventions are much closer to 30 or even 40%. So today we will be discussing the gastric remodeling procedures and specifically endoscopic sleeve gastroplasty. So what are the benefits of endoscopic, bariatric, and metabolic therapy? There are many. So clearly it is less invasive. It may appeal to those who do not qualify for or do not want bariatric surgery. It could bridge a critical gap in the treatment of obesity as it reaches patients earlier with BMIs of 30 to 35 who may not be surgical candidates. It can also be repeated and perhaps used in combination with either pharmacotherapy or other endoscopic interventions. And maybe this is a better disease model for a chronic condition like obesity, as weight is regained even after the most successful bariatric surgical interventions. There's also increasing data on the treatment of obesity-related comorbidities like NAFLD and diabetes. So who are candidates for endoscopic, bariatric, and metabolic therapy? Usually these are patients whose BMI is over 30 and who are not successful at losing weight through non-surgical methods, or who do not desire to undergo surgical interventions. Or perhaps they require a bridge to surgical therapy or other surgical interventions like knee replacements or heart transplants. The contraindications are very much device specific, and so we will not have time to review them in detail here. But suffice it to say, it is very important to note these contraindications and individualize patient care accordingly. So as I mentioned, we will be discussing gastric remodeling procedures today, and these offer a very durable option for weight loss. These include the endoscopic sleeve gastroplasty, which is performed using the endoscopic suturing device, and two other similar procedures performed with plication devices. Here you can see what these look like in real time. On the left, you can see the endoscopic suturing device performing an endoscopic sleeve gastroplasty. You can see the use of a helical grasping device that allows the ability to perform full thickness sutures in the gastric wall. In the middle and on the right, you can see the two different plication devices. The first is the incisionless operating platform that requires two operators and facilitates the creation of large tissue folds through a snowshoe suture anchor system. On the right, you can see the Endomina device, which similarly allows for placement of tissue plications, but with a lower profile system that only requires a single operator. As I mentioned, the focus of this talk will be on ESG. And as shown on the previous slide, ESG is a procedure in which full-thickness sutures are placed to invaginate the greater curvature of the stomach using the device shown below. These extend from the incisura to the GE junction, creating a narrow luminal sleeve with a small fundic pouch. This decreases gastric volume by up to 70 to 80%. The first ESG cases are described here in this prospective trial that started in April 2012 and represented the first use of full-thickness endoscopic suturing for the primary treatment of obesity. This trial focused on procedure development, reproducibility, safety, and short-term efficacy. It was performed at centers in 5 countries. Following a methodical procedure development phase, ESG demonstrated safety and short-term efficacy in this trial. The procedure also achieved meaningful weight loss during the follow-up period. Currently, the most accepted pattern is known as the U-shaped pattern, or the accordion approach, whereby you can see several sutures placed marching from anterior to above the greater curvature to below the greater curvature and then posteriorly, and then repeated back up the gastric wall. This is similar to the originally described Z-stitch, but with additional stitch placement. And this pattern is felt to be more durable and leads to greater foreshortening. We borrowed from the Z and U patterns and also a third pattern that has been described as a parallel row pattern and created a cable technique. This allows for the creation of ridges or cables along the posterior and greater curvature surfaces, as you can see in this schematic. These cables are then sutured together from the incisura proximally to the GE junction, again leaving a small fundic pouch consistent with other suture patterns. Here is what this looks like in real time. These cables usually are created with 3 stitches each and march up the gastric walls. As I mentioned before, the cables are then sutured together, which significantly simplifies the procedure and decreases the use of the grasping device for every stitch. We have found that this is particularly easy to teach our advanced endoscopy fellows. At the end of one of these endoscopic sleeve procedures, the gastric lumen is considerably reduced in volume, as you can clearly see in this video, leading to a very narrowed gastric lumen. So what is the data for ESG? In the next several slides, I will show you how effective this procedure is. The first multi-center retrospective study included nearly 250 patients at 3 different sites, 2 of which were in the United States and 1 was in Spain. All patients were maintained with the same post-procedure care, and the outcome was % total body weight loss at 6 months and at 24 months. As you can see, the mean % total body weight loss at 6 months was just over 15%, and the mean total body weight loss at 2 years was 18.6%. There were no statistically significant differences in outcomes between the centers. Perhaps most importantly, the single biggest predictor of how patients did at 24 months was how they did at 6 months. And so we have now used this data to support additional interventions and strategies for weight loss in patients who are not achieving their weight loss goals at 6 months. A subsequent systematic review and pooled meta-analysis, including 8 studies in over 1,700 patients, have found very similar results. So of the 209 patients that were enrolled, 85 were assigned to undergo endoscopic sleeve gastroplasty, and 124 were assigned to the control group, which was aggressive diet and lifestyle interventions. They were followed for 52 weeks, as I mentioned, and then those who underwent endoscopic sleeve had the option of retightening, and so 18 patients underwent a repeat or revisional endoscopic sleeve. The patients in the control group were offered crossover, and so 81 patients were eligible to cross over to endoscopic sleeve gastroplasty and undergo that procedure. So looking at the outcomes, the mean excess weight loss was 49%, with 77% of patients having an excess weight loss of over 25%. Furthermore, the mean percent total body weight loss was 14% among responders and 13% over the control group. There was significant improvement in metabolic syndrome, type 2 diabetes, hypertension, and quality of life. Liver fibrosis measures also improved considerably following endoscopic sleeves. And this study, along with several others, allowed for the device company to be granted marketing authorization for endoscopic sleeve gastroplasty and the use of this device for the primary treatment of obesity. And when we look at a comparison of endoscopic sleeve gastroplasty to surgical sleeve gastrectomy, we know that while surgical sleeves may be somewhat more efficacious, endoscopic sleeves are much safer. They lead to decreased adverse events, decreased length of hospital stay. Many of them are performed just in the outpatient setting, and a significant decrease in reflux between the two interventions. So surgical sleeves historically lead to significant reflux, and we just do not see that with endoscopic sleeve gastroplasty. There are also studies to suggest that endoscopic sleeve gastroplasty may be even more effective when anti-obesity medications are added as well. And I think more and more data will be coming out on this exciting idea. ESG is also very safe. So we know that ESG-related severe adverse events were very rare in the MERIT study and occurred in less than 2% of patients, and there was no mortality or ICU stays required. We also know from a prospective study of 1,000 patients who underwent ESG that the percent of perigastric collection, severe abdominal pain or nausea, blood loss, or fevers were all less than 1%. We also have data to support that ESG is very durable. So we have good 5-year data that was published several years ago demonstrating that percent total body weight loss at 5 years was maintained at 15.9%. Furthermore, over 60% of patients were able to maintain a percent total body weight loss of over 10%. And in those patients who regain weight or who have plateau of their weight loss, ESG is very repeatable. So we're seeing more and more studies looking at redo endoscopic sleeve gastroplasty and the success that ensues. So in conclusion, endoscopic sleeve gastroplasty has proven to be a safe, effective, durable, and also repeatable procedure. This is a rapidly growing field with many new and evolving devices and techniques in order to perform these gastric remodeling procedures. With growth brings the potential of simplifying these interventions and even broadening their adoption. The most exciting aspect is some of the combination therapy, so gastric remodeling procedures plus anti-obesity medications, or gastric remodeling procedures plus duodenal interventions. All of these are on the horizon and will augment weight loss and also treatment of comorbidities of obesity. All of this, of course, should be performed in the context of a comprehensive multidisciplinary center where patient care is individualized. Thank you very much.